Wow, so a little bit into the lion's den. I'm feeling very vulnerable at this point in time, but yeah, thanks very much to Chris. I'm actually, not surprisingly, very happy to come up and speak about the benefits of a redo AVR and what it means for us technically, but also to the patient population and what the benefits should be. So my name's Karen, I'm one of the cardiothoracic surgeons at the Freeman Hospital. I do have some qualifying statements. I'm not actually supported by industry at all. I'm still relatively young, so probably over-enthusiastic and not quite jaded just yet. I do specialise in major aortic, but that does include aortic valve reconstruction, so I'm heavily interested in the aortic valve and what we can offer patients. But actually, I'm really passionate about improving patient care, so actually if there's technological advances, if we can do things better, I'm certainly not against that. And just to prove that, I actually work with cardiologists up at the Freeman, and I'm very happy to offer TAVI to appropriate patients who are going to really benefit from it. So let's take this forward. I, like Chris, just to qualify for this, I'm going to talk about structural valve degeneration as the problem in an isolated redo AVR. So we're not talking about a patient who's got endocarditis or somebody who needs to come back and has got patent grafts, and I think that's probably the fairest way to do the fight. So what is involved in a redo? Because we talk about redos and we say, oh, and I'm sure that most patients, if you ask them when they come back, do they want to undergo another operative procedure? The answer would be no. And I think if I was the patient, I would probably say the same thing. Do we just automatically say that it's higher risk? I'll show you some of the data to support and go against that. But it's all about the preoperative planning. And surgery has really progressed just in the same way that TAVI has progressed. And it's really interesting now when I go to the cath lab and we're doing our alternative access TAVI program. We give a plan. So when we do our hug at the beginning, we have an ABC. You always need to have a plan A. So it's all going to go fine. We all want to get out for dinner on time. We're not expecting any complications. And we're going to talk through the team what plan A is. But we must not forget plan B. We all know what the complications are. We all fill them in the consent form. We all know what can go wrong. We should be able to predict them. We should be able to tell the team, and we should have a plan for when that happens. Plan C is something that you need to do out with time with your team for when the complete unexpected happens. And that's when you go basically to labs and you basically work with your team as to say, well, this is, if this happens, how are we going to crash onto bypass? What are we going to do? And I think it's really important that you build that in, and that's something that in the world of surgery we're pretty bad at doing, is knowing what our plans are going to be, and that's something that I've learned from joining up with cardiology, and I think that has made a massive difference. It's not going to be unexpected what you're going to find. The dissection of adhesions from previous surgery, they're much easier to deal with. It's safer the longer the time period from the original surgery. So once you get out 1 or 2 years from the original procedure, it's going to be much easier and less sticky as you go in. You know what you're going to need to do, and actually for an isolated redo AVR, it's a pretty small area that you need to expose. It's actually really convenient to do it as a mini sternotomy or a mini thoracotomy, because actually there's only a small area that you need to access. You need to be able to safely cross-clamp. You need to take out that old valve, and I would challenge to say that actually you need to be able to decide how much ppm you're going to have after an operation. That's something you should do at the original time of the operation. We need to get much better at selection of valves and thinking about hemodynamics that we offer to patients. Then we implant the new valve and inspect it afterwards and make sure it's got the quality and the standard that we want to leave the operative room. It's much easier demonstrated in pictures. So this is a first-time operation. This is removal of a papillary fibroelastoma. You look at the bottom of the screen, you can see this is the retractor in silver. So this is exactly where I stand, and this is the view that I look whenever I see the aortic valve. This is the papillary fibroelastoma here. You can see the thickened tissue on the aortic valve. But look at the definition. You can see the fat, it's nice and bright and yellow. You can see that arteries are nice and white on the outside and on the inside. You can see that veins are purple. It's very easy to see what you're doing. Let's compare to the redo setting. I don't have any intraoperative pictures of redo AVRs, but this is somebody who needed a redo from previous grafts in AVR and needed to have a debranching of their aortic arch for an aneurysm. So you can see here the loss of tissue definition. You basically just see red. And even when you put the spreader in, it's only the fresh tissue that hasn't been operated on before that's actually very easy to define. So that's what it is. It takes your day from doing 2 cases in a day to just doing 1. You're going to focus entirely on that patient. That's probably the only case you're going to do that day. So that's what's involved technically in a redo. But when we talk about, are we just going to put in a smaller valve? Because that's always what we get back. Yeah, we need to think about that, don't we? Because actually, going back in and taking that valve out, the tissue is now pretty fixed. If you operate on a 20-year-old for an aortic valve replacement and you compare that to an 80-year-old, tissues are much more elastic. You can increase valve size, you can put in bigger valves. You can't do that in someone who's much more older and the tissues have degenerated. So we actually need to then look at technology and see, can that help us? So these are the most latest advances in the surgical valves that can actually really help in this setting to improve hemodynamics and get better gradients through the valve. And you can see that actually the technology is completely stolen from the world of TAVI. So we're actually improving care by using things that we've learned in the same setting. This is a balloon expandable valve. You can see it's got the cobalt chromium stent frame, which is covered in a cloth, and the balloon comes in through the middle. And we see much better hemodynamic performance in this valve as compared to the standard surgical valve. And it's not really a surprise that we've got the self-expanding nitinol stent, the ability to have this crimp to give a much better view and to be able to deploy the valve. It's deployed exactly anatomically in the same place that you would do when you implant a TAVI, except instead of having to look for radiological markers, we can actually just examine and see where the base of the leaflets is. So direct comparator, balloon expandable, in the TAVI, nitinol self-expanding frame, put them together, and actually, we've got exactly the same valve with the same technology. But here's the difference. We're going to take that old valve out. When we talk about durability of valves, and we talk about tissues and how they fracture and how they calcify over time, all tissue valves are going to fail. Even TAVI valves are going to fail. You just haven't implanted them in people young enough, and that's the lessons that we have learned in the world of surgery. And the advantage of the redo AVR is you're going to take that old valve out. So you're back to baseline. And if we improve our hemodynamics in the valves that we put in, then we're definitely going to have superior results. So just direct comparison, sutureless versus TAVI or rapid deployment, depending on which one you use. We've got balloon expandable, self-expanding. We do see reductions in gradients that really matters to patients. And we also see slightly higher permanent pacemaker insertion rates, which you also see with TAVI. So it's not unexpected to do with the way in which the valve is deployed. But what about real life risk? As I can stand and go through papers, and it won't surprise you to know for every paper that Chris shows you, I can counter it with a different paper. Let's look at what really goes on in the UK. And this was printed in BMJ Open just last year. And what was really nice about this was the world of surgery actually collaborated. It's a bit of a rare event. There's 30 units in the UK, and 27 of them came together and said, do you know what? Our results are much better than what they had in Partner. Our results are much better than the trials that we get thrown at the MDT. Let's have a look at it. We submit all our data to NICOR. To get that data back out of NICOR cost us £5,000 for every request. It was going to be an exorbitant amount of money to get that data out. So we all just resubmitted our data to one central centre at St George's and said, have a look at it and tell us how we do. So they looked at surgical AVR first time. So yes, redo's not included in this. But it's really interesting to see that's all comers. They didn't exclude emergencies. They didn't exclude urgent cases. And they looked at all Euro scores. And in actual fact, isolated AVR first time round for the whole of the UK was at 1.9%. It's a really low risk procedure. And individual units have got it down to as low as 0.9 or 0.5. So we're definitely getting better, we're getting slicker, and we're not offering high risk procedures. So now the question is, what happens when we throw in that redo element in the real world? So the only way to really look at that is to go to the Blue Book. This is the most updated version of results and outcomes up to 2021. Won't be a surprise to know that I can't pull out the redo AVRs from that because this is all they publish. But what's really interesting is here. This is 2008, 2009. Our experience in redo procedures, all redo procedures, just slowly, steadily takes a massive decline. So we're not doing it routinely as much as we probably should be. And that's probably because we have technology. When TAVI came in, actually, it is much easier to refer on for a TAVI than it is to go through a redo AVR. But is that the right thing for the patient? So this is local risk. This is where I work. And it's really important when you consent somebody to not use international data. That patient's in your region, they're coming to your centre. What's your wound infection rate? How many pacemakers do you put in? If I'm the patient, that's what I want to know. So this is what we quote them. Our first time isolated AVR risk is 0.9, and for the redos that we do, it's 1.8. So it's exactly higher, probably by double, but it's certainly not prohibitive. And just to throw in the literature, in between valve and valve TAVI and redo AVR, there's plenty of trials that show that actually there's no difference in mortality. And in the surgical trial for CERD-IR, they actually did minimally invasive redo AVR through a mini sternotomy and saw no difference in hospital mortality whatsoever. So a lot of the basis of, oh, well, it'll be riskier to have surgery, it's not really founded. And if you look at the morbidity of the redo AVR, because that's what we're talking about, what happens as the years go on, because these questions are going to come up. We are putting in more tissue valves than we ever did, and it's not related to age. The use of mechanical valves is definitely falling. So these questions are going to come from much younger and younger patients. And it's actually the rate of PPM that we really need to worry about. There's no doubt at all this is probably just exactly what Chris presented, but in the most up-to-date format. And actually, everything favours valve and valve TAVI, except when it comes to performance of the valve in later years. So take it back to the patient. This is my brother-in-law. This is 3 years ago when he had a stroke. He had a bicuspid valve that we didn't know about. He had endocarditis, and he needed an AVR. Nightmare. Where do I take him to? What does he want? He's really active, high functioning. He's an investment banker. Nightmare patient. Everything's private. Everything's Chelsea and Westminster. Ended up at the wrong hospital. Needed transferred to the NHS. You name it. It was a disaster. Really young kids. Kids that I really care about. What are we going to do for him? And it was really interesting. We had this conversation. He's automatically sent to a surgeon, automatically told he was having a mechanical valve, and automatically I got a phone call to say, this man is barbaric. Who is this surgeon? Do you work with him? You know, there was no conversation, there was no consent, and he was quite upset that his views didn't matter. This here, small scar, was the thing that really mattered to him, because he felt that represented that he had the best, because the surgeon who could do it through a small incision must be the best. I was horrified. I talked through what type of valve he should have, how long it was going to last, re-intervention. In that time frame, in that 3 days that we had to get him to the person, I had a list of about 9 surgeons and I knew all the things. And I said, what is it you want? Do you want somebody who's going to be very attentive, review you before, review you afterwards? Do you want someone who does small incisions? Do you want someone who offers this type of valve? And this was the only thing that he said. What did he get? He got a standard paramount magnet E through a mini sternotomy. Despite having active endocarditis, he actually only stayed in hospital for 5 days. He was reading a newspaper at 11:30 on the day of surgery in ITU, going out for beers and plenty of curries and things by day 3. Because actually, it's not necessarily a disaster to have surgery, and it doesn't have to be a horrendous experience. 3 years later, he's back to work. He's doing Ironman competitions. He's skiing all the time now that COVID has finally relapsed. He's really wearing that valve out. He was not as active when I said it's okay to have that tissue valve and don't get the mechanical one. So this is going to be a really real question, and it's not just going to be in the older age population, it's going to be in the younger age population too. A lot of young patients are getting tissue valves. And what do we really need to do for them to offer them the best? Because the thing is, what would you want? So I told you what Spencer wanted. From a patient perspective, it all made sense. But now I take all the literature that you can read and you can understand, and you know a lot about what a pacemaker means when you're 41. You understand what happens with PPM. You've seen it. So what are you going to recommend? And we need to combine these two things. So it's not completely paternalistic, but we help patients to make the right decision. I'm going to guess it's this. This is what I want. I want the best physiological valve. I really don't want anticoagulation. And I want the least disruption to my life that lasts the longest. And I really want to have age and sex matched survival. I don't want to live less just because I've had an intervention and a prosthetic valve. But this is kind of the truth, isn't it? So what came out of this study in Canada from Catherine Otto is what actually happens to your life expectancy when you have a prosthetic valve. And it kind of makes for quite disturbing reading. So the reality is we probably only intervene in most patients once in their lifetime. And if you're less than 65, your median survival is 16 years. And if you look at freedom from reoperation for valve dysfunction, it's got to have had an impact. And it's only 52% once you're in this age bracket. But we really need to go back to basics about what the best valve intervention is. And it's a procedure that's often lost and forgotten, and it's not offered in many places around the UK. And once you understand why that valve operation is the best one that's offered, then you can understand more about what we need to do with technology to keep advancing things. So the Ross operation, the 2-valve operation rather than the 1-valve operation, again quoted as being higher risk, prohibitive to patients, something that you wouldn't want to go through. But I don't know, life expectancy of 35.4 years when you're 40. It's pretty good. It's much better than 16 years that we're offering with a bioprosthetic valve. Here is what happens, general population. This is the Ross life expectancy. Even with the redo procedures, having to go back in for the pulmonary valve, having to look at aortic annulus dilatation. It's pretty good. But why is that? Why is that still the best valve? And you meet surgeons who'll tell you it's not the best valve. There's plenty of evidence out there that it is. It's the hemodynamics of the valve. It's the fact that you've respected the physiology of where the valve sits and how the root works. Here is, at discharge, mean gradients in these valves for Ross patients. The whole idea is they're not limited. They can generate higher cardiac outputs. They're not putting as much stress in the valve. It's a physiological valve, just moved from one location to another. And it's also associated with that lower mean gradient at follow-up. So it continues, it works on. And that's because of this. You're not really just treating a valve. You've got a whole unit that works in physiology, one with the other. We talk about an annulus of a valve. To us, the annulus is this crown shape. In TAVI, you really look at what we call a basal ring. You're looking at the nadir of the leaflets and getting to the base where the valve is, and you're basing that radiologically where calcium sits. And that's why you learned very, very early on that you're too close to conduction tissue, so the higher you get the valve up, the less pacemakers you have to put in. But this all works in continuum, and the valve is not passive, and it's under stress. There's a reason why the sinotubular junction and the sinuses of Valsalva balloon expand out. There's a reason why it's not a cylinder. And it expands and it contracts. So it all works together. We used to think the valve was passive. It's completely not. The root complex acts as a hemodynamic system. When you respect that physiology, and we get our technology to a stage where we're really improving that, that's why we see superior results with Ozaki. That's why Ross is so good. But in conclusion, patients definitely want what they feel to be the best. And that's different for every patient, and that completely matters. Hemodynamics matter. That's what we know as healthcare professionals. There are surgical valves that offer that, as well as being able to remove that stented frame, better EOAs, and in the longer term will definitely perform better than valve and valve TAVI. Redo AVR is not a prohibitive mortality risk, and hopefully it's not a terrible experience for the patient if we keep improving surgical care. We all have a responsibility to calculate PPM, inform patients of what matters, and then take their decision into account as to what they want. And we should offer redo surgical AVR when it is needed. Thank you.